Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the cystitis. It is the infection of the urinary bladder common in both but more in females. It could be descending from the kidney along the ureter to the bladder. Ascending from the urethra is the usual cause. Short urethra and instrumentation may be responsible. Lymphatic spread. The rich lymphatic network at the base of the bladder which communicates with the prostate, seminal vesicles, cervix, uteri and rectum can provide a pool of infection. From adjacent structures, fistulous communication with the intestine, vagina, fallopian tube and suprapubic cystotomy. Hematogenous. Interstitial cystitis is the example. Predisposing factors: prostatic obstruction, urethral stricture, stricture of external uretary meatus, diverticulum of bladder, pregnancy, cystocele and injuries, and diseases of spinal cord which causes incomplete emptying of bladder. Presence of calculus, foreign body or neoplasm in the bladder. Lack of resistance due to intercurrent diseases and A vitaminosis, etc. Organisms. E. coli is the common infecting organism. Other organisms are Streptococcus faecalis, Streptococcus aureus, B. proteus and Streptococcus albus. If there is presence of pus cells without organisms, calls for repeated examination for Mycobacterium tuberculosis and gonococcus. Having eliminated these possibilities, the condition may be abacterial cystitis. Clinical features. The severity of symptoms varies greatly. Of acute cystitis are more distressing, but some chronic cases weed them in intensity. Frequency. It is the most standing symptom during the day and night. May result in incontinence in severe cases due to infection and loss of sleep. The patient looks drawn and haggard. Pain. If the inflammation is in the dome of the bladder, pain is referred to the suprapubic region. If the inflammation is in the trigone, the pain is referred to the tip of the penis, perineum and labia majora. Hematuria. The passage of few drops of blood-stained urine or blood-stained debris is common. Pyuria. It is always present except in some cases of trigonitis and interstitial cystitis. If urine is passed into two glasses, the second glass is more cloudy. There is tenderness over the bladder suprapubically, per rectum or per vaginum. It is necessary to differentiate between cystitis secondary to pyelonephritis and primary cystitis. Absence of tenderness over the renal angle and a normal or slightly elevated temperature also point to a non-renal origin. The absence of urethral discharge or a tender swelling of the prostate eliminates the primary focus in the urethra or prostate. The midstream urine should be sent for bacteriological examination for culture and sensitivity. Excretory pyrography and normal renal shadows substantiate the Renal origin of infection. Cystoscopy. In women, it is done to confirm the diagnosis during acute phase. The appropriate may vary from hyperemia, mucosal hemorrhages, severe sloughing and ulceration of the mucosa. In men, cystoscopy to exclude predisposing causes should be delayed until the infection is controlled. Treatment. Treatment should be started immediately and changed if necessary after receiving the bacteriological report. Advised to drink plenty of water. In severe infections, it is good practice to commence treatment with nitrofurantoin 100 mg QDS. It is sensitive against E. coli and other pathogenic cocci. Failure to respond or early recurrence of the infection indicates the necessity for further investigations. When the cystitis is under control, every endeavor should be made to search for the primary focus of infection or remove a predisposing cause. That's all about the cystitis, and in the next video I will discuss about some other disease. Thank you.